prevention of dementia and cognitive decline. I have to share with you a message because the two speakers in the room is Rabbi Shaddad, from professor at the University of Bologna, and me. I'm Myrra Vernooij, professor at Radboud University in Nijmegen, the Netherlands, and former chair of Interdem. But the other speakers, they could not come. And we have one on video, and the other two, it was last moment cancelling. And the good thing is that they already prepared their presentation. And Rabbi suggested that we are going to wear masks when we were home, but we are too lazy to make masks. But anyway, Rabbi will do the lecture of Marieke Perry, and I will do the lectures of Karin Wolf-Ostermann, but I will start with my own lecture. Sorry, can I use this microphone? Okay. Well, I will start with a basic question on what is social health and how can we define social health in the context of dementia. Yes. And we study social health in a big joint program project, JP&D project, and social health means social health and reserve in the dementia patient journey. And here is our group, and Karin is standing, well, I will indicate, for good reasons, I will indicate who is Karin. This is Karin. And Marieke, she is not on the And we are with a large consortium, as you might see. Well, what was the reason to study social health? The very reason was that dementia is a multifactorial syndrome, and we should take this really serious because the origins of dementia are not fully known and there is no cure at the moment. So we have to look at all aspects that might be relevant and that might give us solutions for dementia. And among them is social health. But what is the case? We lack conceptual clarity. When we started, we didn't know exactly what social health was. We had a feeling that it could be interesting. There were some associations, but we didn't know it exactly. And a lot of terms were used interchangeable, so that you get lost and you get no information on social health, but just on single terms. And that was a reason for us to write the research proposal, and we were very lucky that we got this huge grant. The aim of this very study, or of this presentation, is first to start with developing a conceptual framework, and that was absolutely necessary for the consortium because we had to speak the same language, and we engaged in developing it with 23 people, which was a challenge. But that's the best way to implement it and to get it used, at least in the project. And, yeah? Okay, thank you. You can hear me now. So if you can't hear me or when we are switching microphones, please let me know. And, well, if you start, if you have to explore something, you have to look broadly. And that is what we did. We looked at epidemiological associations, We looked at theoretical models, and we looked at concepts. And the theoretical models we looked at were the social network model and the cognitive reserve model. And I will explain in detail the concept we used. Well, the first pleasant surprise were the findings on the associations between social health and cognitive functioning, and the consistency. And that's really important. We found markers of poor social health, so markers is the same as characteristics or a variable, and we use markers to have the same language as biologists to make the bridge easier. So markers of poor social health, such as poor social engagement and social isolation, were found to be associated with incident dementia. There was inconsistency on the role of loneliness, but there was a kind of consistency on social health markers such as frequency of contact, social engagement, the social network, and social leisure activities being associated with better cognitive functioning. Thus, better social health, better cognitive functioning, and poor social health, poor social functioning. And there was there were thoughts on mechanisms, and it was supposed that this may contribute to good social health might contribute to cognitive reserve and maintenance of cognition in old age. Well, we did not only look at the associations, that's good to have this empirical knowledge, but we are keen on knowing something on mechanisms, and there is no one theory about it. And we looked at theories that are in place for a long time and proved to be beneficial especially in social sciences. And one of them is the social network model from Lisa Bergman from 2000. And the assumption is that the social structures of the network itself shape the flow of resources, which determine access to opportunity and constraints on behavior. So there is a connection between social health markers or characteristics and behavior. This was one theory we could work with, but we wanted to connect it with cognitive functioning, and the other theory we used is cognitive reserve. And this is a theory of hope. It's brain's ability to use brain networks more efficiently or to recruit alternative networks in the presence of pathology. So basically it's about bypasses and efficient use of what is already in place. And we combined the two in a hypothesis, in our social health hypothesis. And this is that social health is a driver for stimulating the use of cognitive reserve through active facilitation and utilization of capacities of both the individual and the social network, and that this might slow cognitive impairment or maintain cognitive functioning in old age. Well, this is a quite general hypothesis, and this has to be translated, and this is what we are already doing into specific hypotheses that can be tested. So this came out of our studies on methodology, on associations and theories. And then we had to come up with a definition of social health, at least one we agreed upon as a consortium. And this is also the fruit of many discussions and we have an interdisciplinary consortium, so many times people said, I don't understand, and then we had to explain better. So social health is social, which is essentially a relational concept, in which well-being is defined on one hand to the impact that one individual has on others, on the social environment, and on the impact that the social environment has in turn on the individual. So that's the relational concept. So having a concept in place is nice, but it's very abstract. So we had to make a step in between, and therefore we developed domains of social health. And there was a definition of social health in place of Huber, and she defined 3 domains: the capacities to fulfill, the capacities of people to fulfill their own potential, so that they could be who they are, and to comply with societal norms. The other one was autonomy, so that you stay, that you do a part of what you really are and not giving in to everything which is required by the environment, and social participation. The last one is very well used everywhere, and there is a lot of agreement upon. The first 2 is much more complicated. So this is a frame we built, and with that frame we looked at our databases. We have 20 huge epidemiological databases which we could use in our study, and in which we could study associations ourselves. So we did a lot of literature research on associations, and now we are looking for associations ourselves, and the next presentation will be about these associations. And we found associations between neurobiological and social health markers again. So that confirmed what we already found in literature. And with the social network, the conceptual framework, we were able to identify social health markers. So we had an idea, this is social health, and we have to look at these more specific domains, and then we can identify what constitutes social health. And to make it short, it was so encouraging, and our conceptual framework was used by the consortium, so it was feasible to use it. And our conclusion that it's timely to recognize the role of social health in the multifactorial dementia syndrome. So to include it in epidemiological research, and include it in a proper way with validated measures. And to end with why social health is so important. It's a lifelong development, so it's really amenable to changes. You can change it yourself, and you can use it. And it's not related to defectology, so it's a kind of positive signal. It's you can use it, you can do something about it, and you can use especially the capacities the person has itself and the environment has. And the nice thing is a connection with normal life. So we are thinking about, we are thinking about interventions, but you can do an intervention immediately yourself. Now, like we are sitting here, working very hard for a long time, ignoring the social environment. We should not do that. We should honor our social environment and keep it vibrant and stay into connection with our social environment. So that's something we can do tomorrow. And actually, we did during this conference, and I noticed, and I myself also did, how much we enjoy being together, networking, and this is really a joy in life. So it's not a sour medicine to take, but it's joy to be used. And it has potential for both prevention and, well, kind of treatment in the course of dementia. This is it for the moment. I of course have much more to tell, but I will stick to the time. I don't know. I have a clue of whether I did, but okay.
Thank you, Myrra, for your presentation. I don't know if there is some question about, but my suggestion is maybe to go on with the presentation because they are all related to the same concept, social health, and then maybe we can reserve time at the end to discuss this topic, maybe hearing the other presentation. So now I will give the floor, not the floor, radio, the video, not the floor, for Jane Maddock from UK. She cannot be here, but she sent us her presentation by video, which will present results coming from longitudinal study regarding the interaction or interrelation between cognitive health, social health, from data coming from longitudinal study. So if you can go on with the video, thank you.
Hi everyone, my name is Jane Maddock and I'm going to talk to you about social health and change in cognitive capability among older adults. And this work is part of the JPND Shared Consortium and funded in the UK by the Alzheimer's Society. And so apologies I can't be there in person to speak to you about this today, but do feel free to send me an email with any questions you might have. So just in terms of the background, so researchers have theorized that social health can influence cognition through a number of different pathways, including physiological, psychological, and behavioral pathways. And that given the complexity of these mechanisms, it's likely that individual social factors will have differential effect on specific cognitive. Empirical evidence for the association between social health and cognition has grown over the years, and there have been a few systematic reviews looking at this topic. One review in 2017 looked at markers of social health, including social activities, social networks, and social support, and they found 39 studies that examined this. And what they found was that the most common measure of social health that was been looked at is participation in social activities, and a global measure of cognitive function was the main outcome examined. And overall, what they found was that social activity, larger social networks, and greater social support were associated with greater global cognitive capability, with mixed findings for domain-specific cognitive capability, and fewer studies again providing evidence for cognitive decline. Another group from the Netherlands conducted a systematic review and a meta-analysis which restricted studies to longitudinal designs of cognitive decline. And they looked at social health in two aspects, so one being the structural aspects, so that includes things like the size of the network and frequency of contact, and then they looked at functional aspects such as the purpose of the relationship. So overall, what they found was an association between greater levels of social support and less cognitive decline. But there was a lot of heterogeneity, and that could be due to the aspect of social health or the marker of social health measured, as well as some methodological differences between the studies. And they also did find some evidence for publication bias. So given some of this evidence, the direction of the association indicates that overall better social health, the better the cognitive function. But there is still some heterogeneity in terms of how social health was conceptualized between the study, heterogeneity in terms of which cognitive measures were used, as well as different methodological approaches. And this would be really useful to tease apart when trying to understand mechanisms to find effective interventions. So in this study, we used a clear framework to operationalize markers of social health, which is a concept covering a range of individual and environmental social markers. And this work was led primarily by Myrra within the Shared Consortium, and we also drew on work from Berkman and Huber. So we make a distinction between structural aspects, which include things like marital status, network size and contact frequency, and functional aspects, which includes things like social participation and feelings of social support. In this study, we also examined both specific cognitive domains, such as memory, executive functioning, and speed of processing. And we also used a coordinated analysis across our 4 studies to reduce between study heterogeneity. So overall, our aim was to examine whether social health markers that were measured at baseline are associated with a difference in mean cognitive capability at any time point or in the rate of cognitive decline over an 11 to 18-year period. So we included 4 European studies. 2 of these studies were from the UK, 1 from Sweden and 1 from the Netherlands. And this slide shows you the study details, but very briefly. So one of the UK studies was a birth cohort. So this is following a group of people born in 1946, followed up over time. And we have 16 years of follow-up in this study. The other UK study was from a sample that began in 2002, 2003, and included adults aged 50 years and over. And this was an 18-year follow-up. The Swedish study, again, included a sample of adults who were aged 60 years and older, followed up over a period of 12 years. And the Rotterdam study included adults aged 45 years and older, followed up for 11 years. So we selected our outcomes of memory, executive function, and speed of processing based on similarity across the studies. And we also standardized these outcomes across time points and within studies to enhance comparability of estimates between the studies. And this slide outlines how each of these tests were measured within each study, and you will notice in some cases that some studies were missing data on some of these outcomes. So in terms of exposures, again, we categorise them as structural or functional aspects of social health. And although the questions were slightly different across the studies, we harmonised them as much as possible. So we included married or cohabiting, a network size in the following categories, and contact frequency in these following categories. In terms of the functional aspects, we looked at participation in social activities, and we also had information on both positive and negative perceived support. And we categorised these positive support due to the distribution in some of the studies. For the first step of our analysis, we conducted within-study multi-level modelling using random intercepts and slope. So first, we included the social health marker and time in the model and interpreted the coefficient for social health as the association with levels of cognitive capability on average over time, which we refer to as average cognitive capability. Second, we included an interaction term between the social health marker and time and interpreted this coefficient as the association with the rate of cognitive decline. In the second step of our analysis, we combined all of these estimates using a random effects meta-analysis where we pooled all the estimates together, and we included the following adjustments in our models. So taking quite a quick look at the descriptives, we can see that the majority of people across studies were from a non-manual social class. This was particularly evident among SNAC participants. We also saw that most people didn't have IADLs at baseline. When looking at the structural social health markers, we can see that most people were married or cohabiting, particularly among the UK studies, but distributions were similar for the other structural social health markers across studies. For the functional social health markers, you can see that positive support is a little bit skewed for SNAC in the Rotterdam study, indicating that most people were reporting having quite high social support. So just on to the main results now. This forest plot looks at the association between marital status and cognitive capability on average over time. So these red dots indicate your meta-analysed results and the blue dots indicate your study-specific results. And you can see the more transparent dots here are your different adjustments levels, with the most prominent one being your fully adjusted models. And each panel here represents your specific cognitive domain. So if we just focus on the red dots, we can see that being married or cohabiting is associated with higher levels of executive functioning, with sort of less clear associations for marital status or for memory and speed of processing. However, we do see with these figures here that there's quite a lot of heterogeneity. And so estimates from sort of ELSA and SNAC here showing clear associations between being married and higher memory and executive functioning. But less clear associations being seen in the other studies. We also looked at associations sex stratified, and although there wasn't a statistically significant difference between sex, we did see clear associations between being married and higher scores on all cognitive measures for males, but not for females. This series of graphs shows the association with cognitive decline in each of the studies. On what we saw that those who were married or cohabiting at baseline tended to have a slower rate of decline in all 3 cognitive domains, but the effect size was relatively small, being 0.01 standard deviation per year. But again, there was quite a lot of heterogeneity between the studies. When looking at network size, there was slightly less heterogeneity that we observed across the studies. And when we look at the pooled results, we can see really that higher the network size, that being greater than 6 people or none, was associated with higher scores on executive functioning and processing speed. Having a larger network size was also associated with a very small slower rate of decline in memory and processing speed. And when we look at contact frequency, really only ELSA showed any associations with cognitive outcomes, and this wasn't really seen for processing speed. And we didn't observe any associations between contact frequency and the rate of cognitive decline. When we look at social participation, we see that the more social participation, the greater the average scores on each of the cognitive domains are. And overall, we're seeing that the greater the social participation, the slower the rate of cognitive decline in all domains. When looking at positive social support, if we just look at these two panels first, we can see that the people in the sort of middle of the distribution compared to those receiving very low levels of positive support tended to have a higher scores on cognitive functioning, but that this attenuates among those who have very high levels of positive support. But we're not really seeing any associations between levels of positive social support and the rate of cognitive decline. So results from negative social support are similar to those of the positive social support, whereby those in the middle of the distribution tend to score higher on levels of cognitive functioning, but those in the very high distribution compared to those at the reference level tend to have no association with cognitive functioning. One potential explanation for this is reverse causality. It may be that those who are in receipt of very high levels of support at baseline tend to be those with the lower levels of cognitive functioning. And again, we're not seeing associations between levels of negative social support and the rate of cognitive decline. So in terms of the conclusions of this, so overall, we did find evidence that social health was associated with cognitive functioning. We found that structural aspects were more consistently associated with executive functioning, and there was some evidence of sex differences for marital or cohabitation status, but no evidence for sex differences for the other domains. We found that functional aspects were associated with all cognitive domains, but that the decline estimates were quite small. But we did see some heterogeneity that remained, so this could be due to some measurement differences between the studies, some small study design differences, or it could be due to sort of true country differences in results. So in terms of the next steps of this, so we're hoping to explore in a bit more detail some mediation analysis to identify some specific mechanisms that link aspects of social health to cognitive domains. So I appreciate that was a lot of information to take in. We do have all of this as a preprint, and again, I'd be happy to respond to any questions via email. I just want to acknowledge all the co-authors and the funders and the SHARE consortium. Thank you.
That Jane give us some more information about the relationship between social health, also on a longitudinal point of view. And now I want to give the floor for Karin Wolf-Ostermann.
Okay, I will try to do my best.
The interplay between social health and dementia, a dynamic system. Thank you, Myrra.
Thank you. You hear me? Okay. Well, this is a literature study. It's on social health and dementia, and it's a huge literature study. And the hypothesis used to guide this study is that social health has a substantial influence on cognitive decline and onset of dementia, and that social health impacts cognition through multiple pathways, shaping the nature of brain reserve and cognitive reserve. So this is the background of the study itself. And the research, the specific research questions are, what are the biopsychosocial factors impacting the onset, course, and progression of dementia, and which causal pathways play main mediating roles in the interplay of social health and cognitive functioning and dementia. And we do this with the aim to develop an empirically tested comprehensive causal model on the dynamic pathway between social health markers and cognitive reserve and cognitive decline and dementia. And we aim to outline entry points for social health prevention and intervention in dementia progression, because this is the ultimate goal of what we are doing, to find factors that can be influenced. Well, we used a very complex methodology in which we used a mixed method design based on theoretical models, epidemiological evidence, literature reviews, and qualitative and quantitative data. And we did a group model building, so a group of us did a literature review, they developed a model, and then we discussed the model. And we integrated the knowledge into a system dynamics model for prevention and intervention. It took us some time to understand it, and I hope you quickly understand this framework now. And we try to map the longitudinal trajectory of social health across the patient's journey. In fact, we dedicated most attention to prevention and not to the course of dementia, and that should really be done. And here is the model. I don't expect you to read it in detail, but they made beautiful colors, and that might be a bit helpful. It's called a causal loop diagram. And in the literature study, and it's already published, so you can look at the details. And at the end, I will also present a slide on that causal loop model where you can find more literature. The causal loop model comprised 73 factors clustered into 6 domains of cognitive health. We found in the literature physiological factors, 23, social health factors, 21, psychological factors, 14, environmental factors, meaning the wider social environment, not only the immediate social environment, demographic factors, and lifestyle factors. 57 factors by systematic literature review we found, and an additional 16 factors by the social health cluster. You can see they colored it green, so you can find it easier this way. And we came to the final model by discussion session and expert discussion. So it was really an iterative process in which, and there's a lot of uncertainty in this kind of models. This is really exploration, and what we wanted to achieve is to have the relevant factors included, and we hope we did. We are never sure, but we did it systematically, and what is not in was out the system. And here we made a causal pathway model, starting on the left with social health as a course. Then in between, physiological, psychological, and health behavior mediators. And then we thought it would work through brain cognitive reserves. And it's light green here. And at the end, it would influence cognitive functioning that consists of 1 main and 6 sub-areas. So this is the complicated model, but I think it's rather cleaned up in the last one. And the conclusion is that we gained novel knowledge using this mixed method. So quantitative data have the highest status, but qualitative data often give the most information, and we did combine it. So we went beyond the usual methodological path, and we are behind it. We built a comprehensive and multidimensional depiction of social health in dynamic conjunction with cognitive functioning and defunctioning and dementia. And as I said, we used mixed methods. We identified main causal pathways connecting social health with cognitive functioning and dementia. And I already told we used the model of Bergman as a starting model. And what we are doing now, we try to identify potential risk and protective factors for intervention planning. So the end of our project will be these factors, and then we have to build interventions around it, or just give public health advices on how to behave better socially, and also the targets for interventions are at the individual and at population level, so there will be interventions at both levels. And here is a list of when you are interested in this model building, which is a new technology. You can find it here. Thank you for your attention.
Thank you, Myrra, for holding on this job. And I think the topic of complexity is coming up in the domain of dementia. It's not a single cause, but really complex issue which we have to deal with, from social to physiological to other factors. So I have now to present myself. I am not Marieke Perry. Okay. But I am part of the shared study, and I am involved in the international part of this qualitative study. I am going to present today the Dutch study on this topic, and give you some information about the international study, because the international study we are completing the analysis of the interview. So we start with the Dutch study, and then we move to the international study. Two concepts I think that are already known by you. First, the concept of Huber on social health. So the capacity or the potential to fulfill capacity of people with dementia, independence, and social participation are seen as individual capacity which can be which are needed for people with dementia. But also the other focus which come up from social health is that at least in the case of dementia, the direct social environment may have a key role in the utilization of this potential. So that means that how other people act with him, how other people refer to the person with dementia can have really an impact on the use of the potential by the person with dementia. So the qualitative study, as I say before, it is two-part. One started in Netherlands, which I will present the results today, which looking to understand the mechanism. And at the international context, we are also trying to see if there are relevant social markers in the context of dementia, also irrespective to differences in culture and socio-economical status. So it can be interesting to see independently from culture or other factor if the topic of social markers can be relevant for people with dementia. So what are our two research questions used in both the study? The first one, how the interaction between the person with dementia and their case social network members affect the functioning of the person with dementia. So looking to the other side of the social health, not the individual side, but the other side, so which is coming from the environment. And which mechanisms play a role in this? So trying to identify which are the categories or the teams that can play a role in this interaction. So the design is a qualitative study. So we perform individual interviews. So we develop first interview book, interview guide. So just to guide the interviewer about, and we interview four cases, which means that we interview first the person with dementia, then we interview a primary family caregiver, which is a person who is in contact with him. We interview one person from the social network. We define it at least he meets the person at least 2 times by month, so someone who is in touch with the person with dementia. And also we interview the primary professional involved, because the primary professional can play an important role and have an impact on how the person with dementia can feel or act. So we take also into account the sampling, so we take into account age, gender, relation with the informal caregiver or the family caregivers, the living situation, education, and the date of diagnosis. So not only people early diagnosed, but we take into account people who are diagnosed from some time or some years. So how we collect data. So in-depth interview, they start in the Dutch in Netherlands in spring 2020 and end in the summer 2021, whereas the international study start in 2021 and end in this 2022. So they are following action. So as usual in qualitative interview, we said that we will get saturation of data, so we will not have more information after 10 interview for each case, so at least 40 interview. And then the interviews had been coded independently by 2 researchers, following the process of the grounded theory approach. So starting from code to subcategories, categories, and then coming up to have an idea, which called a theory about how things can work or function, or a framework for these aspects. So these are the data on the sample we interview. We have 10 cases, so 39 interview, 10 persons with dementia, which are 5 male and 5 females. We interview also not only people with Alzheimer's disease, but also with vascular dementia or other dementia. The informal caregivers, we had 7 partners and 3 are child. While in terms of social network around, so we interview child or other family members and other from the network, and as professional mainly, because it is done in Netherlands, mainly they are case manager, and then other are one. So to identify people, the method had been to ask geriatrician or geriatric nurses or also case manager to identify person who can be included in the study, to give him a basic information about the study, and to ask him if the researcher can contact him to move on with the interview. So if they give the consent to do this, so they move on with the interview. So this is the participant characteristics. Dementia diagnosis between 2012 and 2020 mostly are married to people with dementia are living alone, widowers. Education ranging from primary school to university, and the social network ranging from poor to extended. Interview at least last more than 30 minutes with a person with dementia. So we have a wide range. So just to give you a figure of what can be a preliminary theory, so we are completing. So the main point is we use these two concepts, which is safe environment, or at least safe social environment, not safe environment, and dignity. So what are element or component or factors which can have an influence on this main issue, a safe social environment and the dignity of the person with dementia. So if you can see the arrow in green mean a positive effect and the arrow in red mean a negative effect. So as you can see, active acts of involvement, we mean by that the others, there are an active act by the social environment in the involvement of the person with dementia. It is a positive and a positive effect with a safe environment for the person with dementia, and it's a concept of dignity of the person with dementia. The part regarding trust, reciprocity, humor, appreciation are all, how you say, giving the floor or giving the importance or involving again the person with dementia. It is important and are positively related to safe environment and dignity, and also the possibility for the person with dementia to share experience with someone is also related, not directly, but through reciprocity, appreciation with the safe environment and dignity, which are other aspects which influence negatively. First of one, dementia symptoms, namely which come up the suspicious attitude of the person toward, and also, as you can see, it is related also with the attitudes of mainly of informal caregivers, the tendency to patronize or to correct the person and to give him advice on how he has to do, and they are negatively related to the concept of safe environment and dignity of the person with dementia. So there are factors which are positively influenced positively, but there are factors coming from the other which had a negative impact on the person with dementia. It's just to give you some quote about what they say. For example, about active acts of involvement. She loved it when the neighbor invite her for a coffee, and I am surprised to hear how she engaged in conversations there. So it is really how they can stimulate this humor, or regarding reciprocity, I need to be able to return a favor when somebody does something for me, then I feel valuable. So the reciprocity in terms of involving him and giving him a role, a place, a possibility to give back what he received. While I know suspicion can hinder the dignity and the involvement, I feel like I can only join them for a walk because I pay for the drink. That make me angry. So if just, or when my mother cannot keep up in a conversation, deliberately leave her out of it to avoid mistake and feelings, and also correcting. So it really depends on how the attitude of the other can influence really the well-being and the capacity and the potential of the person with dementia. About the international study we are going on, it's just what we are trying to collect in Poland, Australia, Italy, Indonesia, Germany, and the Netherlands to have an overview also in other countries of how it works, what are factors that influences. Or we choose to have 3 cases by consortium. No, we use the previously information gathered from the Dutch study in terms of code book, open coding, no, and also using the shared conceptual framework which had been already presented. So we want to reach 20 cases and 69 interviews across all countries just to identify. So just to conclude, can say that safety and dignity are key for the person with dementia functioning, but this can be preserved by others, not by himself. So the other really play a key role, and also social environment really play a key role. So maybe we have to focus on what type of intervention we can develop on the social environment in order to support and to well-being of people with dementia. Thank you.
Yeah. And now the floor is yours. We have 5 minutes for questions. And we will try to do our best to answer the questions related to the presentations of our colleagues. So who can I give the floor for a question or an overarching question? Is everything very clear? Yeah?
Work? Yes, it does. Thank you so much for the presentations. I have find it very nice to hear the perspective on social health. And I've seen that you are looking into the different levels, so the micro and macro level. But how can we make this also relevant on a meso level, that also policies should cater more of a social health perspective?
Well, excellent question, and it's a question with we are dealing with for a long time, and we are fully aware that most of what we are doing is on the micro level. And we decided that this was already complicated enough, and we stick to that level. But you are completely right. There is the meso level is very important, and the macro level as well. But for instance, the role of stigma is very significant, and we should consider that, and we should make interventions in that area, and they are already in place, luckily. But so far, we dedicated our efforts to the micro level, and it's just a start. It's just a start, and we consider that as a start, and we hope that we provide the material that others can build on this. And this, I'm happy, in fact, that so many of you are still here, and maybe it's useful for you.
Absolutely, thank you.
If I can add something, if you remind that the biopsychosocial model, it is on since 1977 by Engels, but there is a lot on biological, psychological is growing on, but social need really to be explored and defined, and this is, I think, a great job to do now, so to explore it and to exploit it.
Well, and adding on that, we were surprised that the social aspect got so little attention, and also in Interdem it's heavily driven by psychologists, and they do a great job. So it's also with a kind of guilt that we started to better look at social health, already being mentioned by the WHO organization in the, more than 70 years ago. So it's really timely to do something.
Yeah. Snorri Ravsson, University of West London. The epidemiology is very important, and this is something I've been involved in for many, many years, and it somehow feels like we are not really moving. Methodologically we are making good progress, and hopefully towards some kind of a causal understanding. But can you give us a sense of where we are with interventions and how we translate this evidence into effective interventions? So compared to the observational evidence base, what's the state of status of interventions at the moment, and what's the sort of the path forward?
Yes, this is something we try to dedicate also this conference to where are we at this moment with psychosocial interventions, and there are very few who are explicit with regard to social health, very few who are explicit, and a lot of work has to be done. And but we started with them, and we learned already a lot about the barriers. So people don't want to have a specific psychological or social interventions to be to be less lonely, for instance. That's connected with shame, and they don't want to be mentioned. That we have the impression that it's less stigmatizing to have a psychological problem than to have a social problem, and also people refuse to collaborate in social intervention. So it's just the beginning, and we have to, a good social support is provided hidden. So you don't say, I'm coming to visit you because you are so lonely. That's an offense. But you invite someone like here to come and drink a cup of coffee, and so we have to, in a way, we are starting with a kind of hidden support, social interventions. So where are we? Rather in the beginning. Last question.
Thank you. My name is Nis Peter Nissen. I'm director of the Danish Alzheimer Association, and I'm not a scientist. I'm a bureaucrat working how to translate your science into actual improvement of people with dementia's lives. My question here is, I have attended a lot of conference during the years for other diseases, health conference, and the social health is an aspect in other diseases as well. In fact, very often you see that a deteriorating social health comes before a deteriorating physical health, and diseases develops faster if you have a poor social health. So my question to you is, what is the reciprocal connection between deteriorating cognitive function and social health? Thank you.
I think I can say something. Yeah, you raise an important question. The topic of social health is already present in many other diseases, particularly chronic disease. So it is very present. But there is, I think, some differences between what we call what are social determinants of health, which is a long life issue, social determinants of health, and what contribute now in the well-being of a person who have a type of chronic disease. I don't understand which can be the differences. So in the literature, there are a lot of literature about what can be social determinant of health. For example, socioeconomic status rather than being poor or other things. So these are social determinants of health, and they influence health status, access to services, and so on.
No, my point is loneliness is very often the primary cause of deteriorating health, right? So my point here is, what is the cognitive decline in relation to a decline in social health, for example? There is also that connection, right? How does that influence both people?
Well, the thing is that cognitive decline really influences the social interaction, and that people feel embarrassed about their cognitive decline, and that therefore they try to shield, to hide away, because they don't want to be recognized as a person with declining capacities. And this is crucial if we want to improve social health. So, and well, that's the case, and that comes from many qualitative studies, including ours. But you can do something about it. So it's not necessary that it stays like that. It's important that in the immediate environment, people are aware of the condition and deal with it, and still continue to be in contact, and still, well, about capacities. Often it's said, oh, the person is no longer him or herself, and that is always saddening me, because the person is still there, and you should look at what is still in the person. And well, as a daughter of a mother with dementia, I can give you an advice. What we did is we kept our mother in the mother role. We kept treating her as a mother, and we were greatly rewarding for it, because we had her until the end of her life. So we can really do something about it. It's not just a disaster, but do something with it, and don't let them isolate themselves, or don't isolate them. It's so important.
Myrra, if I can just add to what you're saying, in the context of cognitive decline, it's quite typical that people will have communication disorder, as well as it being the stigma and the loneliness, their reaction of their family. So it's actually dealing with the nature of the communication difficulty. So addressing the linguistic difficulty, training up partners in how to communicate better with their person with dementia, and helping them to access social networks and stay more active, and reducing the likelihood that they'll be lonely and isolated. So there is actually, the cognition is having a very significant impact also on communication ability. So there's a communication disorder there, as well as, I suppose, the other psychological, environmental factors that are there. As a speech and language therapist, I think dealing with the communication impairment side is a way of, it's a very positive, there are some positive interventions that are validated for people with dementia in terms of improving their social networking and communication. So it's important to look at that side also. There is hope. Thank you. I just wish that I had been, I suppose, exposed to some of your social health measures before I had undertaken my PhD. But I'm delighted that you shared them with us today. Thank you very much.
Thank you. Well, I realize we are over time, but thank you for staying here, for your interest and for your question. And I hope you are going to use social health as a concept in your studies. Thank you very much.